Hi, everyone, and welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database New Data Manager webinar. Today is Wednesday, September the 29th, 2021. I can't believe we are at the end of September and getting ready to start October. So let's get started with our agenda today. On the call with me from the STS team, we have myself, Carol Crone, Addie Dolan, Sydney Clinton, and Ruth Raleigh, our GTSD consultant. For our agenda topics today, we'll cover an introduction to the STS and the databases, the role of the data manager. Next we'll roll into how to read the data collection form. We'll go over required fields. We'll give an introduction to the data specs, an introduction to the training manual. We'll go over submitting a clinical question. We'll cover keys to abstracting data. We'll discuss building a relationship with your surgeon. How to ensure clean data. We'll review data submission deadlines, and then lastly, we'll give a review of additional STS resources that are available to the data managers. So I'll start things off today. Again, just wanted to give you a visual, put some names to faces. So here we have Donna McDonald. She is our fearless leader. She is the Vice President of Quality. We have Jane Hahn, the Associate Director of Quality. Carol Crone is our Senior Clinical Manager for all of the STS national databases. Catherine Hollyfield is the National Database Manager for Intermax and PDMax. And myself, as you're all aware, I'm the Database Manager for General Thoracic and the Congenital Database. We also have Emily Conrad. Emily is our STS National Database and Patient Safety Manager. You guys also should be very familiar with Emily. She's handling all things at AQO, so she's not able to join us today. Many of you also deal with Derek Steck. He is our contracts manager for the STS national databases. Sydney Clinton, she is our quality and database operations manager, and many of you have worked with Sydney directly regarding public reporting. She handles all of the STS public reporting initiatives as well as TQI. Banu Yagusi, and I apologize, I don't know if I said her last name right, so forgive me, Banu. She is our STS quality measures manager, so if you work with the submit any minor data requests or any research requests, those would you would work with Banu directly. We also have Addie Dolan. She's our senior coordinator for the STS National Database, and Addie works with you all directly with the participant contacts, all things STS National Database. Addie keeps us all straight, so Addie is on the call with us today. And then also we have Ruth Riley. She is our core group member and our GTSD consultant, and Ruth is out of St. Joseph Mercy Hospital. All right, so I'll give a quick introduction to the STS and the STS national databases. So the Society of Thoracic Surgeons was founded in 1964, and the mission of the society is to enhance the ability of cardiothoracic surgeons to provide the highest quality care through education, research, and advocacy. Today, the society has more than 7,500 members in 99 countries and more than 65 employees in Chicago and the DC area. The society is one of the smaller societies found out there. So again, we are a smaller group compared to other medical societies. We are, again, just over 65 employees in the Chicago, DC, also North Carolina area, and Alabama area, as I work remote, as well as Catherine. So the first database was started in 1989 as an initiative for quality improvement and patient safety among cardiothoracic surgeons. And this was a direct response to HHS and HCFA, as they were using claims data to determine outcomes of cardiac surgery. And this was not taking into account the risk of patients entering the operating room. Thereby, we were not comparing apples to apples. And of course, this led to inaccurately sharing of poor outcomes. So in response to this, the STS surgeon leadership had decided that it was their responsibility as a society to correctly share outcomes, taking the risk of the patients into account. And then, of course, this led to the start of the first STS national database, again, in 1989, the adult cardiac, and then the subsequent development of those risk models for the adult cardiac database. And again, off of the adult cardiac database, this has further evolutionized into the development of the general thoracic surgery database, as well as the congenital heart surgery database, and their associated risk models. Also, many of the malpractice lawsuits related to a misperception of the risk associated with surgery, they were on the rise using the claims data as the true source of outcomes. So the development of these databases did help define kind of the incorrect thought of the poor outcomes versus the realistic expected outcomes by the development of these risk-adjusted outcomes. Also, JCAHO's requirement of all health systems to have a quality assurance program used for surgeon recredentialing led to the development of the databases, as well as threats to reimbursement. Some accomplishments of the STS databases, we have improved patient outcomes, patient safety. We've developed clinical practice guidelines, for example, blood conservation and antibiotic usage. We have voluntary public reporting, and it has been shown that sites who publicly report do tend to have better outcomes. We have multiple risk models for all of the databases, multiple NQF measures for each of the databases. And then we also have governmental support. We have research utilization through RUC, as well as surgeon reimbursement. We have consensus statements, and the database-driven research has led to the advancement of care, technology, and the improvement of outcomes. Just a little bit of background, the General Thoracic Surgery Database started in 2003, and today we have more than 880 surgeons at 275 sites, both nationally and internationally. We have 2 international sites, and they are located in UAE and Singapore. As of, I believe I got these numbers, these are current as of July. The General Thoracic Database contains more than 719,000 records for more than 612,000 patients. So that's pretty impressive. All right, the data abstractor, data manager. So you are very smart, you're creative, you're meticulous, organized, you're passionate in a good way. You're very passionate in a good way. Most of you are nurses. Some of you are health management specialists. Also, some hold other roles. We have both clinical and non-clinical data managers. But just know, no matter your background, you are all making a difference, and we greatly appreciate every single one of you, and we are so happy to have you as part of the STS National Database. So the role of the data manager and data abstractor. Your roles are to abstract the data, submit the data, make sure you have clean data, develop quality improvement projects at your facility, charting, come up with best practices, and also your role is to help improve workflow on units, improve teamwork, quality assurance, participate in the quality assurance meetings with surgeons and supporting departments, and also work with your administration on reporting on your star ratings. All right, so next we're going to turn things over to Ruth, our GTSD consultant, and Ruth's going to take over the presentation, and she's going to give a review on reading the data collection form. So Ruth, it's all yours.
Thanks, Leanne. Are you going to switch slides for me? Sorry, I didn't ask.
Yes, I'll
okay.
Yeah, I'll advance for you.
Great, thank you. Okay, so let's get started talking about reading the data collection form. So which variables are required on the data collection form? So the STS thinks that all variables are important. The parent and child relationships will help reduce the number of data elements that you have to enter when you collect data. Do not omit any fields that are included in the analysis report. So things like mortality, the required variables, and risk model variables. Complete all of the fields consistently so that they're meaningful internally and over time. So when you look at the data collection form, how do you determine which fields are the required variables? If you note the variables are underlined in blue. So in this case, is the patient's race documented, the age, the gender, and then the race. If you answer yes, you have to enter the race. Those are required variables. things like Hispanic or Latino ethnicity, not underlined in blue, and so not a required variable. However, again, the STS finds all data elements to be valuable, and you're going to want to collect that information so that you have consistency for internal use of data within your institution. So then when you look at the data collection form, you'll notice that there are now weights assigned to procedures. So what's the purpose of these weights? So the lung cancer resection, for example, is weighted at 60, whereas the esophageal resection has a weight of 70. It's unlikely that you have a lung cancer and esophageal resection on the same patient, but sometimes you'll see something like a thymus resection done in conjunction with a lung cancer resection. So which one would you select as the primary procedure when you code this case? Well, the weight will help you make that decision. So in the instance where you have a lung cancer and a thymus resection together, you would make the lung cancer resection the primary procedure because it has a higher weight. Sometimes this will help you realize that you've perhaps coded something incorrectly. So if you're doing a thymus resection and they do like an en bloc wedge resection of lung for thymus tissue, you would be directed to code lung cancer resection if you had incorrectly selected a lung cancer resection code. And you might scratch your head as a data manager and think, well, that doesn't make a whole lot of sense. And it doesn't make sense. So you would then perhaps rethink and say that wedge resection is a concomitant procedure, is weighted at 20. My thymus resection is still going to be the primary procedure. So use the weighting system to your advantage. If it doesn't make sense, it doesn't make sense, and rethink what you've selected, perhaps. How do you know which procedures to collect? So for version 5.2.1, you have to submit all lung and esophageal resections that are done for cancer. So those are included in this first block of cases, the major analyze required procedures. So confirmed lung cancer resections, confirmed esophageal cancer resections. In order to know whether it's a confirmed or a suspected lung or esophageal cancer resection, you're going to have to look at your final pathology first. And you're only required to enter cases that are confirmed cancers, not suspected cancers. These procedures are risk adjusted. So when you get your harvest report back, you'll see the risk adjustment for those cases. Things that the STS considers major analyzed procedures that are not required for entry, but are optional procedures are those things that fall into thymus, mediastinal mass, myasthenia gravis resections, the tracheal resection, and the hiatal hernia resections. You'll see these referred to as the optional cases or optional modules. These cases aren't analyzed in the same way that the lung and esophageal cancer resection cases are because there is no risk adjustment. However, you will get benchmark data back in your harvest report. So you sort of can see where you compare to the STS without any risk adjustment at all. You're not going to get a star rating for these optional modules. You'll just get benchmark data back. The next category on the data collection form is what they call the minor or non-analyzed procedures. These are accepted into the database if you choose to collect, which is different than the procedure that it's a difference between the way the DCRI and IQVIA sort of has analyzed or looks at the data. So because they're accepted into the database now with IQVIA, you're required to enter all of the required fields that are part of the on-save check. You will get an error when you try to upload these cases if all of the required fields aren't there, even for your minor or non-analyzed procedures. A concomitant procedure is always collected on the same data collection form as the primary procedure that's being performed at that time. Okay, so the data and software specifications. The database is updated every 3 years. So we just had the changeover to version 5.2.1 from version 2.4.1. The data and software specs are key tools in that process. So it's important to understand how you read the information that the STS provides. So in each, you can look over on the right-hand side of your screen. You can see that the each procedure has a long name and a short name, and then it'll tell you what section that variable falls into, and then the variable is defined very specifically. It will also tell you whether there's a parent field. The long name of the parent field would be included underneath the long name of the child field that you're entering, so that you know perhaps why something didn't open up. And I think that that's confusing. Sometimes people will wonder why they're seeing two variables listed, and it's because one is the parent to the child. And then there's requirements that are provided to the vendors so that they know what allowable options are permitted to be selected. So allowable values, there are a lot of the numerical values have allowable ranges. And in some instances, you aren't allowed to enter outside of the allowable range, but in most, you'll just get a warning. So where I see this most often in my data collection is with number of lymph nodes resected. My surgeons often resect a lot of lymph nodes, and so I very often will get a warning saying higher than usual value. And then it's sort of an opportunity for you to evaluate whether you made a typo, right? And you entered 160 lymph nodes when you meant to enter 16, or whether, you know, the data that you've entered is correct. It's just not usual. Okay, the training manual. So the training manual is probably the most important document that you'll use as you abstract these cases. It gives you guidance on how to abstract each variable. You have to reference your training manual frequently. The FCS suggests not printing off the training manual because it changes so often. It's really a living, breathing document that you have to come back to over and over again. So you can see for this sequence, valvular heart disease, a change was made. An intent and clarification was provided, and then the intent and clarification was updated. And so, you know, as time goes on, as data managers submit questions, understanding changes and grows and different scenarios are provided that allow us the opportunity to clarify really what are we looking for. Some of the training manual updates are easily provided by, you know, Leanne, Carol, and I reviewing questions. Sometimes we take things back to the surgeons and they really mull over what do they want to collect for a specific field, and then changes are made. So the training manual is officially updated once a month with new FAQs. Not every FAQ makes it into the training manual. Some FAQs are simply responded to. Before you submit a question as an FAQ, make sure that you've looked at the training manual to see if your question has already been answered. Something that's new for version 5.2.1 is the FAQ summary document. So we recognize that it is near impossible to read the entire training manual every month. That would be a huge time commitment. And so what we have done is provided you with an FAQ summary that is located right by the training manual and on the STS website. It summarizes what changes were made each month. That way you can just sort of look at those sections of the training manual and make sure that you understand what changes have been made. So how do you submit an FAQ? You are going to need some information when you go to submit your question. You're going to want to have your participant ID available. It's a 5-digit number that starts with a 4. You're going to want the short name and the sequence number, which can be found either on the data collection form or in the training manual. And then as much information as you can provide to help us answer your question. So, you know, we can only answer questions as specifically as the information provided. Very often I'm reaching back out to sites asking for more information. So if it's a very specific clinical question, I would highly suggest including the operative note, the final pathology, an HMP, a discharge note, really all of the information that we're going to need to be able to answer that question with specificity. We don't want to provide a broad answer and misinterpret the question because we didn't have enough data up front. It can take about 30 days to get a response. The core group meets monthly and we get feedback from our surgeons monthly. So if you submit an FAQ the day after we meet, then it's going to be about a month until we meet again. Like I said, we may ask for additional information, and that's because we really want to answer your question with as much specificity as possible. And then I would ask that you please double, triple, quadruple check that the email that you're using to submit your FAQs is correct and complete, because when I respond to your FAQ, I generally respond via email just because there's so much documentation that you're going to need. Responding by phone isn't really very efficient. And so this is what the form looks like. This is, it's on the website. There's a link there, and we'll show you, I think, later in the webinar exactly where it's at, but you're gonna need to put in your name, your email, your phone number, which I'll call you at if I can't get my email to go through and ask for a complete email, your participant ID, and then what database version that you're looking for a response. I will say that the 241 training manual is no longer being updated. We answer FAQs, but the training manual, you won't see any additional FAQs being added to the training manual. Only 521 is getting updated at this point, but we're happy to answer 241 questions still. And then you're going to enter the sequence number and then input your question. Some keys to abstraction: be consistent where you obtain your information from. Something that I did early on in my tenure as data manager here was to develop an Excel spreadsheet that said where I look for each piece of information that I collect, everything from name to smoking history to post-op events. And then I was able to give that to the auditor so that when they audited my data, they could go to the same places. And I think it makes for sort of an easy audit handoff, but it also allows us to be very consistent because, you know, things like pack years can be documented 50 ways in the chart by every person who asked the patient. The patients don't give consistent answers, and all providers can do is document what they've been told. So having a standard place where you pull that piece of data is really helpful. Pay attention to your source documentation. I think we tried really hard in this 521 training manual to give specific timeframes for different sources. So, you know, things like how old can my EGD be for it to count for clinical staging. We tried to put that information in the training manual. So look closely at the date of the documents that you're using. If you can't find something that you're looking for, ask your surgeon or ask for, develop a relationship with their surgery schedulers and their office staff, and they can usually help you find pieces of information. I have a horrible time finding notes from gastroenterology, but I promise you, if I ask my surgeon scheduler, she can tell me exactly where to find that document every time that I can't find it. Don't guess. No data is better than bad data. So if you can't find it, ask. And if it's just not there, then leave that data element blank. Working with your surgeons. Your surgeons are busy. Be patient but persistent. They truly do care about the data that you enter. And I think after you reviewed a harvest report with them, you'll see that they are interested and they want you to do the best job that you possibly can. They're just very busy. So keep pursuing that relationship with your surgeons. Be clear and concise with the information that you need. Develop documents for them that they can find useful. Know what you're going to ask before you ask. Do your homework and know the facts. I never show up to a meeting with my surgeon without having a copy of the training manual pulled up, because sometimes she'll say, well, that's not true. That doesn't make sense. And I say, well, right here in the training manual, this is the definition. And she's always like, oh, okay, yeah, no, you're right. That's the definition. So we'll count that one, that post-op event. Get involved with quality meetings and department meetings where the data is being discussed. I know that it's been tremendously beneficial for me to attend like our morbidity and mortality conferences and different venues where just thoracic surgery cases are just being sort of tossed around, bantered back and forth so that I can learn as much as possible. Asked to observe cases. Generally, surgeons love having you in the OR with them, and they're very good about talking through procedures as the procedures occur. You'll learn tons if you're able to go to the OR with your surgeons. Offer to review the data with your surgeons, make standing meetings whenever possible. Make sure that you're on their calendar so that you have set aside time to really work on the data that you're abstracting, making it the best as possible, and offering them quality improvement process opportunities. Offer tips on how documentation can be improved. So you can offer them, EHR templates that it can be shared between institutions. I know that they have been built for Epic and that they can be shared from site to site. We're currently developing surgeon worksheets for GTSD so that you'll be able to share those with your surgeons. Something that we've done at my site is we have a data collection form that the OR nurses fill out for us. The cardiothoracic APP group also fills out a tremendously helpful patient history form, and it has a handwritten summary. They're actually rounding cards, so the APPs round every day on the patients and put handwritten notes on a little card that we're able to use and that the auditors were also able to use. Work with your nursing and OR staff. They can help you find the data that you need and collect that data for you. Okay, so cleaning up your data. Your vendor will allow you to run internal QA checks on your data prior to submission. I find these to be tremendously beneficial. It's probably my favorite way to clean up data. IQVIA also provides you with a lot of tools to help clean up your data. So the data quality report, the harvest summary report, the critical error report. And I think this is something that the STS is invested in making as helpful as possible for data managers. So please give us feedback on additional tools that you would find helpful in making sure your data is clean at the time of submission. Version 5.2.1 has on-save consistency checks that are built into the vendor software. These prevent you, so initially they were preventing people from saving their data, although that's being transitioned to a process where you just simply cannot export your data if certain errors are present. So if certain elements are missing or inconsistent, then you'll have to go back and correct those before the data can be exported to IQVIA. Data submission deadline. So harvest for GTSD is twice a year, spring and fall. Each report comes along with a star rating. Voluntary public reporting results are based on the spring harvest and is for lung and esophageal cancer cases. If you currently don't voluntarily report, we can show you where that is on the website to sign up for that. Sorry. Next slide. Additional resources that the STS provides. So there's the monthly webinars, the monthly user group calls. There's quarterly new data manager webinars, and all of these are saved and sort of listed for you on the STS website for viewing later. We recognize the data managers are very busy and also scattered across time zones, so we do record those and provide them to you for viewing whenever it's convenient for you. You can also sign up through the mentorship program, and that means you'll get the email address of a data manager who's been doing this for a long time, and that data manager can help answer questions for you. They may tell you that you have to submit an FAQ, but sometimes it's nice to have someone say, yeah, no, you're just going to have to submit an FAQ for that one. It's not in the training manual. AQO is coming up very shortly in about 2 weeks, and there's going to be sessions there on all of the surgical resections, walking the form, the data collection form. We're going to review the 5.2.1 upgrade there. There's it's a virtual conference again this year with live and pre-recorded sessions, and you do get continuing education credits for attending. The database newsletter is also a wonderful resource that the STS provides. So this is what I was talking about with the webinars. So you can see over on the left-hand side of your screen, you can click that link to join the webinar if it's the right date and time. Otherwise, you can look at the past GTSD webinars that are over on the right-hand side, and you can listen to recordings of those webinars. You can also review the slides, for example, by clicking that PDF link. This is how you sign up for the mentorship program. So you're going to go to the STS National Database link under registries, and then you can apply to be a mentee here, and you'll get assigned a mentor. And if you're on this call and you've been abstracting data for a long time and you're interested in being a mentor, we're always looking for mentors too. The newsletter is located not under the registry section, but under the publications section of the STS website. So you go to publications, and then you're going to click the STS National Database News, and all of those are saved for viewing there. And I believe they also get emailed out to us if you are signed up as a data manager. I get them in my inbox. There's also a page for data manager education. So again, if you go under the registries page, STS National Database, there, and then scroll down, there's going to be a section on data manager education. So you can sort of see some of the things that are here, tips for collecting 30-day follow-up data, the STS IQVIA uploader instructions, things like that are located there. And then if you look over on the left-hand side of your screen, the STS has a separate tab next to publications called resources. And there are some resources there that are helpful, particularly for GTSD, things like lung nodule resources, information about COVID-19 that really applies to all the way across all of the registries. And so that is the conclusion of this presentation. We are happy to answer as many questions as you have to ask. We're excited to hear your feedback and answer questions.
Yep, great. Thanks so much, Ruth. That was a great presentation. I appreciate your help with getting this put together and presenting today. Yeah, so if you have questions, everyone, please be sure and submit your questions via the Q&A. Also, I believe the raise hand function is also available. So if you'd like to, talk, you're welcome to do that. So just raise your hand and we can unmute you. Just make sure your microphone's enabled. I do see we have our first question. And then after this question, while we're waiting for additional questions to come in, I can do a quick tour of the STS website and point out exactly, just walk through where these additional resources are located. So I'll do that while we wait to have some questions come in. I can go ahead and answer this first one. It's from Jody. I've been abstracting for less than 2 months in the GTSD, and I was trained on version 2.4.1. Should I actually be using the newer version 5.21.1? So data version 2 for any operations, surgery dates of July 1, 2018 through June 30th of 2021, those must be entered in version 2.4.1. So if you're entering retrospectively, and if you're entering cases from July 1, 2018 through June 30th of 2021, then those should be entered. They must be entered in under version 2.4.1. For any surgeries or any operations with a surgery date of July 1, 2021 forward, those must be entered in data version 5.21.1. So again, version 2.4.1 applies to surgery dates of July 1, 2018 through June 30th, 2021. And version 5.21 applies to surgery dates of July 1, 2021 forward. All right, so I hope that helps. All right. Our next question, Ruth, I think this one's from you. A patient has been diagnosed with primary lung cancer and undergoes pre-op radiation and chemo, then undergoes a lung resection. The final path report from surgery finds no cancerous cells. Should this case be entered into the database since the final path does not show cancer?
So yes, Maggie, you would enter that case. You're just going to use the final pathology report from your initial biopsy for this case. And it happens more often, I think, in esophageal cancer than in lung, but those cases are captured. The important thing is to never use preliminary pathology for any sort of a determination or entering of data all the way across the registry. Always wait to have final pathology results. But if it's post-treatment, you'll use the initial path.
Okay.
And I know we're definitely covering some scenarios like that at AQO. So.
Let's see, Mary. It's good to get affirmation of what I'm doing. Great to know about the number of lymph nodes. The surgeons here are also excited more than expected. Okay, Jody, you're very welcome. Yep, good thing you asked. So yeah, so if you have any more questions, Jody, just please feel free to reach out, and we're happy to help. Okay, does that include updates? Example, patient alive in 1 year. I'm sorry, I don't understand. Ruth, do you understand the context for that one?
I'm not sure. Does that include updates? Oh, maybe about, maybe they're asking about whether they have to include like post-op follow-up for their minor procedures, but I'm not sure.
Okay.
Oh, he put, there's clarification. It's edit of info for 2.41.
I'm still not sure. I'm
Maybe
sorry.
we can unmute this person. I'll find them.
Yeah. Okay. Thanks, Carol.
Mhm.
All right. All right. Why does the data completeness report include blank items that are not expected to be answered? For example, if I'm collecting a case for GERD, but the patient doesn't have a hernia care, I get errors that those fields are missing. Also, if an esophageal procedure is extracted, I get an error for a case that isn't a 1-year-old that is missing 1-year follow-up. Just curious why there aren't checks in place for these things. Okay, so unfortunately, IQVIA is not on the call today, Holly, so I am not able to answer that question for you, but I can find out, look into that more. If you have not submitted, yeah, Carol?
Nope. Sorry, Lan, didn't mean to interrupt.
Oh, no, that's okay. But no, yeah, Holly, I can't answer that one for you right now, but I will find out more information. I will find out more information about that question. So, all right, I've just copied your question, so I'll make sure that I have that, and so I can follow up with you.
And maybe maybe Holly can report that to IQVIA if there's specific fields. It might be a programming issue at IQVIA that they need to be aware of. So it's not displaying as missing if it's not really supposed to be.
Yeah. Yeah. If you haven't submitted a ticket yet, Holly, if you could please do that, and then IQVIA will look into it. And if there's an issue of, some checks that need to be in place and aren't in place, then we would discuss that with them and make sure that those get implemented. Okay. In my example, what about the staging? The pathologist, in my example, what about the staging? The pathologist does not offer any staging information. Is there wasn't really a tumor left after the pre-op treatment?
I think you're asking, what do you enter for your pathologic stage? And if there's no tumor left, then you would enter T0. It would be like a T0, N0, M0.
And the person is unmuted for you, Leanne.
Hello.
Okay. Hi.
Hi, I'm Karen. I'm calling from Delaware. My question is, I'm sorry I wasn't more explicit, but for the 2.41 version, when you need to go back in and correct that patient is alive a year from now, a year from even like May of 21, where do you go to correct that? And these are for like the mediastinal mass resections and the hiatal hernias. So do you go back into 2.41?
That's the way that I do it, and I don't know if it's different by vendor software. I'm sorry, but for my vendor, what I do is I go back into the record where I abstracted the original case, and then I just fill out those fields that were originally submitted blank because the time hadn't elapsed yet.
Right.
And I just add that additional information in at that point in time. So you go back to the 241 record. Yes.
Very good. Thank you for your help.
Thank you. Okay. All right, so our next question from Mary regarding by moments completeness of resection R012 is rarely in the path report op note. Is there a way to find this out by reading the op path note that doesn't specifically say R012?
I would follow up with your pathologist. It's my understanding those should be coming from the pathology report for the most part, unless they think there's like gross disease left, and then that would come from your op note. So I think that's a great question for either your surgeon to take to your pathology department or for you to take to your pathology department, depending on how well you or how comfortable you are with your pathologist. I've found that the pathologists are actually super excited that the pathology data gets used for projects like this. And so they love talking to me about pathology. So if your institution is the same, I would say befriend a pathologist and see what they can tell you. You wouldn't want to just assume completeness of resection if that's what you're asking.
All right, Ruth. Do we need to submit all blue fields for non-analyzed cases?
So yes, the required fields have to be answered for all cases. The only exception would be ECOG score. Yep.
And again, this is because these, and by non-analyzed, I'm assuming you mean the minor procedures. But yes, but they have to be answered for all the cases submitted to the database. Do we need to submit all but mandatory for trach? Yes. So example, do we need to submit all blue field mandatory for trach planned procedures? If you collect that data for these minor procedures, if you collect data for minor procedures, they're submitted in your data and they're submitted in your file and sent uploaded to IQVIA. Yes, you have to collect those blue fields, the required fields for all the procedures. And here's a question about determining size of the tumor. Patients usually have more than one CT pre-op. Should I use the largest size or the size of the tumor indicated in the CT scan closest to surgery? I think that's in the, is that in the training manual? That sounds familiar.
I think it is in the training manual, which I don't have pulled up right this second. So let me pull it up and I will loop back to Maggie's question.
Sorry, Carol, can you hear me?
What's wrong? What's the
Okay.
question?
Okay, sorry. I was on phone audio and I got booted off, so my phone
Oh, we can
died.
hear you okay, Leanne.
Okay, yeah, I just joined through the computer audio, so forgive me if it's a little muffled. Okay, I'm sorry. I know we're looking up that question from Maggie. So Mary, I've pointed out the optional fields that show up as missing to IQVIA multiple times. I've sent them many screenshots and it's out examples. As something I'll just regard those areas because they do not result in the records being rejected. So we sent out a communication to the STS vendors regarding these on-site checks. So that is in process. So Mary, if you have to complete those required fields for those cases. The only one that does not apply is ECOG.
Maybe Mary is talking, I guess maybe Mary is talking about fields that aren't those required fields. And I don't think that that's anything necessarily that's new or unique to IQVIA. When we were with DCRI, I would have pages and pages of errors that I would just ignore because they weren't on required fields. And like I knew, for example, that I always had a hard time finding a specific piece of information that wasn't required. And so I left it blank quite often and I would just ignore it's sort of like a courtesy notification more so than an error. And I would just disregard them.
Yeah, this is Carol. Thanks, Ruth. I agree with that. And I wonder, are they flagging as errors or are they flagging as warnings or versus showing up on the missing variable report? So errors in IQVIA usually when we set something to be an error, it's some type of logical discrepancy, something that just isn't going to make sense logically. So if you're getting, except for the ECOG score, we set the ECOG score to an error because it really is required for all primary lung and esophageal cancer cases, but we don't have an NA in the ECOG field to allow you to code that as missing. So we don't want to exclude that record if you legitimately don't have an ECOG score. So we just set it to an error because of the high priority of it. But if it's another field that's showing up as an error because it's missing, I think we would probably want to know that to check further into it. If it's an error because of a logical issue, then there really may be a logical issue that needs to be checked out. And if you're having a hard time determining why it's firing as an error, we can definitely walk through you with that. The other thing is there's a difference between errors and warnings. Warnings are things like, hey, your lab values look to be out of range. Are you sure these are correct? And it's very common that surgical patients will have lab values out of a normal range. So it's expected that they might be showing as a warning correctly, and you can just ignore those. The variables that the other report is the missing variable report, which will show you any variable that is missing. Now, if for the missing variable report, if it's a parent question is answered one way and you're unable because of the way the parent-child relationships work, you can't get to the children field, but for some reason they're showing up on your missing variable report, please let us know, because we've done a lot of testing on those and we hope that we caught everything and all the programming is correct. But sometimes, when you change one thing on the front end, it kind of moves things around on the back end with programming. So if you're seeing that type of incorrect thing showing up on your missingness report, we need to know so we can correct it, because you're probably not the only one, who's taking time to check your missing variable report. So we want to make sure we have it right for everybody, and so that we're not wasting your time with those reports. So I hope that's helpful.
Yeah, and Mary's she's been adding comments, as you talked to Ruth, and she's, and critical areas result in the record rejection, and the missing variables are at your discretion to fix if you can. And Mary, if you've submitted these, your concerns to IQVIA, which you say you have, and you're feeling a little frustrated and still not sure understanding what's going on, if you would like to just
her statement is you cannot complete fields that don't exist or are required for optional cases. And I would question then, what vendor are you using? And did they come up with a
minor form,
not at the request of STS? And if that's correct, then you need to reach out to your vendor, because STS did not instruct vendors to build minor forms. And we actually requested that they not do that for these reasons. So if it's a vendor issue, if you're using a minor form that your vendor built in 5.21, that was not a requirement, nor was it asked by STS, then reach out to your vendor to have them update that for you.
Yeah, she said she does not have a minor form, but I know, Mary, you've been working with this, and if you'd like to just shoot me an email, and if you would like to just talk to me directly offline, and maybe we could just do a Zoom or something, and we could just take a walkthrough and just take a look and see what you're seeing. So just shoot me an email, Mary, and I'm happy to work with you. Okay, let me see here. Okay. If we collect minor procedures, would they be included in the calculation for mortalities and the star rating? No. So let me pull over. I want to pull, please. I'm going to pull over the data collection form. So, and what you're talking about are, so here's a list of the major analyzed procedures. And what we mean by the minor procedures are all of these procedures here listed with under the blue heading. So no, these minor procedure only records are not included in the calculation, the percent missingness calculations for star ratings. But as discussed on the last webinar, the last user group call, these optional, if you submit these optional cases, yes, those are included in the calculation for percent missing. Due to the mandatory blue field for non-analyzed minor cases, our abstraction time effort will increase by about 300%. We do about 100 non-analyzed minor cases per month. Long admission, non-analyzed cases like lung transplant cases and ECMO cases will be difficult to abstract because the cases are in hospital for several weeks.
Yeah, I can take that. Well, I think Mary just brought up a good point. You can exclude these records from submission. And STS doesn't require these cases to be submitted. So it's up to you if you want to abstract them or not, but Mary makes a good point that you can exclude them for submission.
Yeah, talk to your vendor. If there's a minor only cases, work with your vendor because, you can obviously collect that data internally for your internal purposes. But work with your vendor to see if those minor cases, and I'm not sure, to be honest, I don't know. Work with your vendor to see if those minor only cases have to be included in the export file.
I think it's vendor specifically, and like my vendor allows us to not submit cases based on our discretion, right? And if you get audited, you certainly would have had to have included every single required procedure. And if you're going to submit the optional modules, you need to submit every single optional surgical procedure that you are opting into. But if it's just minor stuff, we can opt out.
Yeah. So again, are you suggesting not to submit these non-analyzed or minor cases at all? So again, just to be clear, these minor cases are, again, these minor procedures under the blue headings. You do not have to submit them. You can collect this data internally. You do not have, STS does nothing with these minor procedure only records. They are not sent over to DCRI for analysis. The records that are the analyzed records are these major procedures here, and the optional cases, the hiatal hernia, tracheal resection, thymus mediastinal mass. But again, these minor cases here, these minor procedure only records are not, you do not have to submit these. I hope that, let me know if that's not clear. Is there a way to continue to collect the minor cases for reporting reasons and not submit the cases to IQVIA for analysis? That would help. Christine, again, you would have to talk to your vendor. I don't know how their vendor software is set up. So if you choose to collect this data internally, I don't know, you would have to talk to your vendor to see if there's a way in their export to not include, like Ruth has just said, she has the ability to not include these minor procedure only records in their export.
I think this is in our software specs, Leanne, that they can exclude records from the export file.
Okay. Are you looking in the software specs?
No.
Okay. Okay, Peter.
I think you reach out to their vendor.
Yeah, you can reach out. Okay. Okay. All right, I'm just cleaning up my questions so everything is looking okay, so I don't miss anything. Ruth, did you say that if we submit any of the optional cases, then we have to submit all the optional cases?
So my understanding, and Carol, correct me if I'm wrong, but my understanding of the way that the STS prefers that this is done is if you are going to opt into collecting hiatal hernias, for example, that you would submit all of your hiatal hernias, not just some of your hiatal hernias.
Yeah,
but if you opt into hiatal hernia, you don't have to opt into tracheal resection, and you don't have to opt into mediastinal mass. But if you're going to opt into the category, then submit all of the cases for that category, if that makes sense.
Yeah. Perfect.
That's right.
Our missing variable report is showing 100% missing, 93% missing mortality. Parent field is follow up, and we in our last follow-up date, last follow-up recess lab that leave more date blank patient lab, but they have all been captured as missing mortality thoughts. So are you talking about, so 241, are you talking about missing mortality date? So if you're talking, yeah, so missing mortality date, there is no parent field for mortality date. So obviously if the patient is alive, you will not have a mortality date. It is blank. It'll be reported as missing data because there's no parent for that field. So we don't know, we don't have a way to check is the patient still alive. So that's not an issue. So mortality, date does not play into the percent missing calculation and analysis. The variables that we look at for the percent missing calculation is mortality status at discharge, mortality status at 30 days. So again, if your patients are still alive and that mortality date is still showing missing data, it's going to show missing data. Just know that that is missing because the patient is still alive. And again, that's because there's no parent field for that variable. Katie, if anyone has PATS as their vendor and wants to exclude the minor cases, just leave the participant ID question blank and it will exclude that case from your harvest file. Thank you, Katie. That is very helpful information.
And in ARMIS, it's just like because I use ARMIS for my vendor, it's literally a exclude from harvest. You just say yes, and it pops it out.
Gotcha. Okay, Mary, yes, shows is missing, but she just listed your card. Thank you, Mary. Okay, yep. All right. Oh, Maggie's got her hand raised. I'm sorry, Maggie, I didn't see that. Hold on, I'm gonna unmute you. You might have to unmute yourself on your side. Hi, Maggie. It's Maggie Beltran. Okay, I don't know if you raised your hand by mistake. Oh, sorry, it was an error. Okay, no worries. All right.
I can answer the, so I looked at the training manual on the CT question.
Okay.
So what the training manual says is multiple imaging may be available to code this field. And again, this is sequence 1800, which is lung cancer tumor size for the short name. And you're supposed to indicate the tumor size of the dominant most concerning lesion in centimeters. So the training manual says multiple imaging may be available to code this field. If a PET scan and a CT are available, then use the CT if it is less than 3 months old. If the CT is greater than 3 months and the PET is less than 3 months, use the PET. If both exams are over 3 months old, use the CT. The issue that we don't address is if there's multiple CTs in that 3-month window, whether you would use the most recent or the largest. And I can clarify that and I will update it in the training manual.
Okay. Here's one question from Christine. I don't know if Ruth or Carol. How should we attempt to explain to our surgeons that they should not have us make non-analyzed cases as major? For some reason, our surgeons want their esophageal myotomies and diaphragmatic palpations labeled as major. Is there a good reason why they ask that we do this?
I don't understand what you mean by
Major?
I don't understand how you can make something major that isn't, I guess. Because that is determined by the procedure that you code.
Yeah.
Maybe send this in as a question, Christina. Maybe we could have our surgeons look at it, Ruth or Leanne.
Yeah.
Maybe send me some op notes, Christine, where they've asked you to do this and I can sort through them and try and give you some guidance. I'll put my email in I'll type my email here for you.
Thank you, Ruth. And I know we're at just a minute after, but I did want to do just a quick tour of the STS website for anyone that's super new and not familiar with where to locate resources that we spoke about earlier. So I'm just, like I said, just going to do a quick little walkthrough. From the STS National Database homepage, you would just click on the registries button and click on STS National Database. Go ahead and bookmark this site. You'll be here a lot. For the General Thoracic Database, you would click here on the General Thoracic button. And here you can find all the information regarding data collection. Click this button here for all of the data versions. Here we have the 521 training manual, the FAQ summary, the data collection forms, additional resources. Here are the data specs and the software specs that Ruth walked through earlier, as well as there are some itemized changes between 241 and 521 and a change summary document for you out there. And as well, there's all the other previous data versions with their data collection forms, data specs, and such. All right, for also on the STS National Database Registries homepage, sorry about that. scroll down. If you scroll down the page here, you can find information on how to join the database. And then obviously you guys are already participants, but if someone that you know is interested, all information can be found here, as well as fees. Information can be found here under Join the Database. Here's some information on COVID-19 in the STS National Database. Here is our link to the live webinars. Just click on the View Webinars and scroll down. And again, you'll see the information for the GTSD webinars. Click on this button and then you can access all the past webinars. The webinar, the user group call from last week has been posted. And again, this was a pretty long webinar. It went an hour and a half, and I went through and explained the rerun, the missingness thresholds, the spring and fall 2020 harvest report. So, and again, the slide deck is available. All right. So if we go back to the STS National Database homepage, again, if you continue to scroll down under important resources, here's a lot of the information you need. Here's a link to the data manager education that we referenced earlier, a link to your harvest schedule information. Database forms, a lot of times I get questions, where is the participant contact form? I need to add a surgeon, I need to schedule A, I need to add a new contact. So the participant contact form is found here under database forms. So just click here. And again, here's the link for the PCF, the Schedule A, the Schedule B, vendor licensing, and links to the database participant roles description. So all that information can be found here. Again, back to the important resources. Here's the AQO page. All things AQO can be found here. The detailed agenda, information on continuing education, pricing, and the link to register is here. So again, just click here to register. And if you have any questions about registration, you reach out to Amy. Programming and continuing education, you can reach out to Emily. And the other thing that I wanted to show you is the publications, the STS National Database News. Again, this is found under publications. The current issue for GTSD is the July-August issue. We'll have a new issue coming out here shortly. And if you click on the GTSD newsletter, this is what it looks like. Again, this is a bi-monthly newsletter that is posted here on the website, and it is sent out via email. And again, a lot of information here. They have lung cancer screening program information. We have information about the latest GTSD outcomes and research. Annals of thoracic surgery. We have information on 5.21, and I guess there's new information every issue. So again, please check out the STS National Database News. A lot of great information there. And there's also STS News for the surgeons. So check out our newsletters. A lot of important information found here. A lot of good information out on the STS website. And I think that might be, I have 5 minutes after the hour, so I know I want to be respectful of everyone's time. So if you have any questions, or if you can't find anything out on the STS website, please feel free to reach out to me directly. I'm happy to help in any way possible. I hope today's presentation was helpful to you all. And again, if you have questions, please feel free to reach out. That's what I'm here for. And if I can't answer your question, I'll get you to the right person who can. So I just wanted to thank Ruth. That was a great presentation today, Ruth. I'm just going to swing through these slides real quick. And thank you everyone for joining. Thanks Ruth, Carol, Sydney, Addie, everybody for being on today. I greatly appreciate your help. And I hope this presentation was helpful for you guys today. And again, please reach out with any questions.
Really great job, Lan. Thank you, Ruth.
Hi, thanks, Lan.
Thanks guys. Thanks Ruth. Great job.
Thank you.